Good afternoon, my dear students. Today we continue a cycle of lectures for students of third year of education for MA groups, and topic of our today's lecture is a syndrome of heart failure. What is a part of a submodule Signs and Symptoms of Cardiovascular System Diseases. And today's lecture, it is a finish lecture, the last one in this submodule. After it, we will start another submodule about another syndromes of another system. And I'm going to start from the plan of lecture. I'm going to give a definition, discuss classification of heart failure, pathophysiology, different what is systolic, diastolic dysfunction, what is left ventricle and right ventricle failure, what is cardiovascular response, and clinically what are the causes of heart failure, risk factor, clinical classification, clinical picture, diagnosis, complications, and for the last, for your individual work, I have here SNOE test. Let's start. Definition. Heart failure can be defined as an abnormality of cardiac structure or function leading to failure of the heart to deliver oxygen at a rate commensurate with the requirements of metabolizing tissues, despite normal filling pressures, if or only the expense of increased filling pressures. Heart failure is defined clinically as a syndrome in which patients have typical symptoms like breathlessness, ankle swelling, and fatigue, and signs like elevated jugular venous pressure, pulmonary crackles, and displaced apex beat, resulting from an abnormality of cardiac structure or function. Classification. It can be acute or chronic. We told about it. Chronic, another name we can name congestive heart failure. It can be heart failure with high output and low output. It can be systolic or diastolic, left or right heart, or it can be biventricle. It can be dilated or non-dilated, and according to cause, it can be ischemic, hypertensive, idiopathic, dilated cardiomyopathy, etc. Pathophysiologically, in heart failure, the heart may not provide tissues with an adequate blood for metabolic needs, and cardiac-related elevation of pulmonary or systemic venous pressures may result in organ congestion. This condition can result from abnormalities of systolic or diastolic function, or commonly both. Although a primary abnormalities can be a change in myocyte function, there is also changes in collagen turnover in extracellular matrix. Here you see pathophysiological scheme of compensation of heart in heart failure patients, where included is volume overload, pressure overload, myocardial disease, and rapid heart rate that all together lead to poor cardiac output, and it lead to two main pathophysiological results. First, it is decreased renal perfunction and decreased function of renin-angiotensin-aldosterone system with sodium and water retention, and increased blood volume. And another result, it is increased autonomic nervous stimulation. It lead to vasoconstriction according to sympathetic stimulation with pallor, sweating, tachypnea, tachycardia, and altogether it increased left ventricle and right ventricle diastolic pressure with its own result for each ventricle. Progression from hypertrophy to diastolic heart failure. Here on this scheme you see that it is a gradual process that goes during years. In the presence of congestive symptoms, a time of course of heart failure may become progressive and may end with a sudden cardiac death or interruptible end-stage failure. in moment when it starts to be clinical, in a much more short period, it leads to severe heart failure and death. We told several times about systolic and diastolic failure. It is a little bit other processes according to cause. And structure of myocardium will be different too. Like on this picture, in diastolic failure, it usually thick heart walls. It is a sign of diastolic failure that are resistant to normal relaxation. And in systolic heart failure, more typical thin heart walls, which is sign of systolic failure that can't be relaxed, but they can't constrict completely and make function of for heart like a pump. Systolic dysfunction. In systolic dysfunction with reduced ejection fraction, you see it is thin wall that can't constrict correctly, that can't make correct systole and produce normal ejection fraction. A ventricle contracts poorly and empties inadequately, leading initially to increased diastolic volume and pressure and decreased ejection fraction. Many defects in energy utilization, energy supply, pathophysiologic function, and contractile element interactions occur, with abnormalities in intracellular calcium modulation and AMP production. Predominant systolic dysfunction is common in heart failure due to myocardial infarction, myocarditis, dilated cardiomyopathy. Systolic dysfunction may affect primarily the left ventricle and right ventricle. Left ventricle failure often leads to right ventricle failure. Here on this scheme you see on pictures A and B the way how left ventricle hypertrophy and systolic dysfunction through the pressure overload lead to left ventricle hypertension and directly to systolic dysfunction, and finally the left ventricle hypertension lead to systolic dysfunction too. And on picture C, you see that left ventricle hypertrophy is compensatory response to stress-mediated systolic dysfunction. Diastolic dysfunction. In diastolic dysfunction, heart failure with preserved ejection fraction, you remember it's all okay with systole, but it is abnormal diastole. Ventricular filling is impaired, resulting in reduced ventricular and diastolic volume, increased end diastolic pressure, or both. Contractility and hence ejection fraction remain normal. Ejection fraction may even increase as a poorly filled left ventricle empties more completely to maintain cardiac output. Markedly reduced left ventricle filling can cause low CO and systemic symptoms. Elevated left atrial pressures can cause pulmonary hypertension and pulmonary congestion. Diastolic dysfunction usually results from impaired ventricular relaxation, increased ventricle stiffness due to valvular disease, constrictive pericarditis, acute myocardial ischemia, hypertrophic cardiomyopathy, disorders with ventricular hypertrophy, and amyloid infiltration of the myocardium. Abnormal relaxation and increased stiffness are associated with diastolic filling abnormalities and normal exercise tolerance in early phase of diastolic dysfunction. And let's differentiate left and right ventricle failure. First of all, left ventricle failure, like most often form. In this case, cardiac output decreases and pulmonary venous pressure increases. When pulmonary capillary pressures exceeds to oncotic pressure of plasma proteins, it's about 24 millimeters Hg, fluid extravasates from capillaries into the interstitial space and alveoli, reducing pulmonary compliance and increasing the work of breath. Lymphatic drainage increases but it can't compensate of the increase in pulmonary fluid. Marked fluid accumulation in alveoli, like pulmonary edema, significantly alters ventilation-perfusion relationships. In severe or chronic left ventricle failure, pleural effusions characteristically develop in the right hemithorax and later bilaterally, further aggravating dyspnea. Left ventricle injury leading to structural remodeling and dysfunction is the seminal event in the progression of heart failure. Systemic venous pressure increases in right ventricle failure, causing fluid extravasation and consequent edema in systemic circulation. Primarily independent tissues, feet, ankles of ambulatory patients, and abdominal viscera. The liver is most severely affected by the stomach, and intestine also become congested. Fluid accumulation in the peritoneal cavity, like ascites, can occur. Right ventricle failure causes moderate hepatic dysfunction with modest increases in conjugated and unconjugated bilirubin, hepatic enzymes, etc. The impaired liver breaks down less aldosterone, further contributing to fluid accumulation. Chronic venous congestion in the viscera can cause anorexia, malabsorption of nutrients and drugs, protein-losing enteropathy characterized by diarrhea and marked hypoalbuminemia, chronic GI blood loss, and rarely ischemic bowel infarction. Right ventricle failure include increased right ventricle afterload that lead to right ventricle dilation and tricuspid regurgitation. In another way, right ventricle afterload lead to prolonged isovolemic contraction, to increased myocardial wall stiffness that to result to right ventricle hypertrophy and decreased right coronary perfusion. Right ventricle hypertrophy can cause shift of the intraventricular septum, left ventricle failure, and altogether it leads to right ventricle ischemia and right ventricle failure. And mechanisms of cardiovascular response. If ventricular function is impaired, a higher preload is required to maintain cardiac output. The ventricles are remodeled over time. The left ventricle becomes less ovoid and more spherical, dilates and hypertrophies. The right ventricle dilates and may hypertrophy. Initially compensatory, these changes eventually increase diastolic stiffness and wall tension. Diastolic dysfunction develops, compromising cardiac performance, especially during physical stress. Increased wall stress raises oxygen demand and accelerates apoptosis, programmed cell death of myocardial cells. Dilation of the ventricles can also cause mitral or tricuspid valve regurgitation with further increases of end-diastolic volumes. With reduced cardiac output, oxygen delivery to the tissues is maintained by increasing oxygen extraction and sometimes shifting to the oxyhemoglobin dissociation curve to the right favor oxygen release. Reduced cardiac output with a lower systemic blood pressure activates arterial baroreflexes, increased sympathetic tone, and decreasing parasympathetic tone. Heart rate and myocardial contractility increased in this case. Arterioles in selected vascular beds constrict, venoconstriction occurs, and sodium and water are retained. These changes compensate for reduced ventricular performance and help maintain hemodynamic homeostasis in the early stages of heart failure. Next, in cardiovascular response. These compensatory changes increased cardiac work. preload and afterload, reduce coronary and renal perfusion, caused fluid accumulation resulting in congestion, increased potassium secretion, and may cause myocyte necrosis and arrhythmias. And here you see a scheme of cardiovascular response, how left ventricle and here in this example specifically left ventricle dysfunction lead to pathophysiological mechanisms and clinical symptoms. Like for example, left ventricle dysfunction lead to TNF, insulin resistance, malnutrition and inactivity that altogether lead to catabolic state. In another wave, it leads to reduced peripheral blood flow, to skeletal and respiratory myopathy, that can lead to dyspnea, muscle fatigue, increased ergoreceptor activity that in own way lead to increased ventilation and dyspnea too. Increased ergoreceptor activity result in sympathoexcitation vagal withdrawal, to vasoconstriction, increased afterload, reduced peripheral blood flow, and like pathological cycle, it leads to left ventricle dysfunction to worsening like pathological cycle. As cardiac function deteriorates, renal blood flow and glomerular filtration rate decrease, and blood flow within the kidneys is redisturbed. The filtration fraction and filtration sodium decrease, but tubular resorption increases, leading to sodium and water retention. Blood flow is thus redisturbed away from the kidneys during exercise, but renal blood flow improves during rest, possibly contributing to nocturia. Decreased perfusion of the kidneys are possibly decreased arterial systolic stage secondary to declining ventricular function, activates the renin-angiotensin-aldosterone system, increasing sodium and water retention and renal and peripheral vascular tone. These effects are amplified by the intense sympathetic activation accompanying heart failure. These processes causes a cascade of potentially deleterious long-term effects with myocardial and vascular collagen deposition and fibrosis. Vascular and myocardial hypertrophy, thus contributing to the remodeling of the heart and peripheral vasculature, potentially worsening heart failure. Here you see a scheme of cardiovascular response, the same which I described you in previous slide. Chronic activation of neurohumoral responses is detrimental in the normal balance between myocardial stimulated and vasoactive hormones. What hormones? It is B1 receptors are down-regulated, probably in response to intense sympathetic activation. Next, it is plasma norepinephrine levels that is increased, largely reflecting sympathetic nerve stimulation, as plasma epinephrine levels are not increased. Vasopressin is released in response to a fall in blood pressure. Arterial natriuretic peptide is released in response to increased arterial volume and pressure. Brain or B-type natriuretic peptide or BNP is released from a ventricle in response to ventricular stretching. Fewer endogenous vasodilators are produced and more endogenous vasoconstrictors are produced, thus increasing afterload. The failing heart and other organs produce tumor necrosis or TNF-alpha. Here you see a scheme pathophysiological cycle of parasympathetic withdrawal and sympathetic overdrive that altogether lead to heart rate increase, to increased inflammation with excess cytokine release, to nitric oxide dysregulation, and both together have pro-arrhythmic effect. Age-related changes in the heart and cardiovascular system lower the threshold for expression of heart failure. interstitial collagen with the myocardium increases. The myocardium stiffness and myocardial relaxation is prolonged with a significant reduction in diastolic left ventricle function, even in healthy people. An age-related decrease in myocardial and vascular responsiveness to beta-adrenergic stimulation further impairs the ability of cardiovascular system to respond to increased work demands. And here you see changes with aging. If in young patient, in child, in young heart, it leads to enlarged cardiomyocytes and hypertrophy and to cardiac senescent response in more age in adults and old aged people. It leads to more fibrosis, to dilation, to cardiomyocyte stretching and presence of fibroblasts in myocardium. Causes of heart failure. Heart failure can complicate any cardiovascular disease sooner or later. One more time, be attentive with this fact because we told that heart failure it's not a disorder directly, it's not a disease, it always syndrome, and it means that it always have some primary disease that lead to heart failure. Heart failure is always secondary to something. And one more time, attention to this phrase. It can complicate any cardiovascular disease, any of them. All that you learn in cardiology sooner or later result in heart failure. Moreover, a lot of non-cardiovascular disease can lead to heart failure. Let's discuss most often of them. It is coronary artery disease. It is the most often cause for today. It is high blood pressure or hypertension. It is on second place in structure of causes of heart failure. It is atrial fibrillation, valvular heart disease, excess alcohol use, infections, and cardiomyopathy. It is just the most often of them. It is the upper of iceberg because a huge number of different diseases can lead to heart failure. Moreover, it can be thyroid disease, kidney disease, diabetes, heart defects present at birth. Between risk factors, we can name all risk factors that are usual for all cardiovascular disease. Understandable, the same cardiovascular risk factor. If you remember lecture for cardiovascular methods of diagnostics, we discussed there these risk factors. All of them are actual for heart failure because any disease can result in heart failure. It is high blood pressure like hypertension. It is coronary artery disease. It is heart attack, diabetes, some diabetes medications, sleep apnea, congenital heart defects. Moreover, it can be heart valvular disease, viruses, alcohol use, tobacco use, obesity, and irregular heartbeats. Clinical classification of heart failure. We different heart failure by stages according to American College of Cardiology classification. It is one of the most usable classification in all countries in whole world, and it stages heart failure divide on A, B, C, and D. Here I give you an examples of this classification. It can be a little bit other in different sources. A. It is high risk of heart failure but no structural disease or symptoms, or more simply on mistake it look like asymptomatic high risk patients. It is patients with risk factor but without structural changes, without symptomatic. Stage B, it is structural heart disease but still no symptoms, or it is myocardial damage without symptoms. Stage C, it is structural heart disease with symptoms. When it starts symptomatic, it stage C. And stage D, it is refractory heart failure, requires specialized interventions, or end stage of refractory chronic heart failure. And the most usable classification in whole world, according to severity, it is classification according to functional classes by New York Heart Association classification. According to New York Heart Association classification, functional class 1 can be defined as ordinary physical activity does not cause under fatigue, dyspnea or palpitations, or simpler it is no limitation of physical activity. Functional class 2, it's when the ordinary physical activity causes fatigue, dyspnea, palpitations or angina, or simply we name it a mild limitation of physical activity. Functional class 3, when it is comfortable at rest, but less than ordinary physical activity causes fatigue, dyspnea, palpitations or angina. We name it moderate limitation of physical activity. And functional class 4, the last one, it when symptoms occur at rest. Any physical activity can increase discomfort, or we name it severe limitation of physical activity. Clinical picture of heart failure includes shortness of breath, or another name of it, dyspnea, fatigue and weakness, swelling, edema in legs, ankles and feet, rapid or irregular heartbeat, reduced ability to exercise, persistent cough or wheezing with a white or pink blood-tinged phlegm, and increased need to urinate at night. It can include swelling of abdomen, we name it ascites, sudden weight gain from fluid retention, lack of appetite and nausea, difficulty concentration and decreased alertness, sudden severe shortness of breath and coughing up pink foamy mucus. It can be chest pain if heart failure is caused by heart attack. Let's different a little bit left and right heart failure because they are quite different in clinical picture. In left heart failure, the most common symptoms are dyspnea, reflecting pulmonary congestion, and fatigue, reflecting low cardiac output. Dyspnea occurs during exertion and is relieved by rest. And as heart failure worsens, it can occur during rest and at night, sometimes causing nocturnal cough. In paroxysmal nocturnal dyspnea awakens patients several hours after they lie down and is relieved only after they sit up for 15 to 20 minutes. In severe heart failure, periodic cycling of breathing, we name this type of breathing like chain stocks breathing, can occur during the day or night. Sleep-related breathing disorders such as sleep apnea are common in heart failure and may aggravate heart failure. Severely reduced cerebral blood flow and hypoxemia can cause chronic irritability and impair mental performance. In right heart failure, the most common symptoms are ankle swelling and fatigue. Hepatic congestion can cause right upper quadrant abdominal discomfort, and stomach and intestinal congestion can cause anorexia and abdominal bloating. Less specific symptoms include cool peripheries, postural lightheadedness, nocturia, and decreased daytime micturition. Skeletal muscle wasting can occur in severe biventricular failure and may reflect increased catabolism and increased cytokine production. A significant weight loss, we name it cardiac cachexia, is an ominous sign associated with high mortality. In the elderly, presenting complaints may be atypical, such as confusion, delirium, falls, sudden functional decline, nocturnal urinary incontinence, or sleep disturbance, coexisting cognitive impairment and depression. Here you see schematically difference in left and right heart failure. Like in right, it will be congestion of peripheral tissues that resulting in edema, ascites, liver congestion with impaired liver function, and GI tract congestion with anorexia, GI distress, weight loss. On the other hand, left heart failure leads to decreased cardiac output with activity intolerance, signs of decreased tissue perfusion, cyanosis, and signs of hypoxia. And the main sign of left heart failure is pulmonary congestion with autopnea, cough with a frothy sputum, and paroxysmal nocturnal dyspnea. Diagnosis. In left heart failure, tachycardia and tachypnea, hypotension and confusion because of hypoxia and poor cerebral perfusion may occur and help you to suspect a diagnosis. Central cyanosis reflects severe hypoxemia. Peripheral cyanosis of the lips, fingers, and toes reflects low blood flow with increased oxygen extraction. Left ventricle systolic function include a diffuse, sustained, and laterally displaced apical impulse, audible and occasionally palpable in third and fourth heart sounds, and an accentuated pulmonic component like P2 and second heart sound S2. Pathosystolic murmur of mitral regurgitation or at the apex may occur. Pulmonary findings include early inspiratory basilar crackles that do not clear within coughing, and if pleural effusion is present, dullness, tuberculation, and diminished breath sounds at the lung bases. It can be tachycardia and it can be different arrhythmias, pathological types of tachycardia. The most severe of them you see on this ACG. In upper strip it is ventricle tachycardia, it looks like this on ACG, and the most danger case, it is the last one, it is ventricle fibrillation, which is equivalent of stopping of heart working, and it is a possible result of heart failure. Central cyanosis is caused by abnormal composition of hemoglobin such as sulfhemoglobin and methemoglobin, or decreased in the saturation of the oxygen because of cyanotic congenital heart disease. Pulmonary embolism, pulmonary edema required urgent treatment, and severe respiratory disease. Peripheral cyanosis can be a result of causes of central cyanosis and can occur in isolation. Common causes of peripheral cyanosis without central cyanosis are peripheral vasoconstriction due to cold, Raynaud phenomenon, or beta blocker drugs. Reduced cardiac output due to cardiac failure or hypovolemia. Peripheral vascular disease, venous obstruction with a deep vein thrombosis. And here you see objective changes with the typical heart sounds possible in heart failure. And different cases in aortic stenosis, mitral regurgitation, aortic regurgitation, mitral stenosis, and other problems. Diagnostic of right heart failure. Non-tender peripheral pitting edema like digital pressure leaves visible and palpable imprints, sometimes quite deep. It is the most simple and the most typical objective way how to check lower extremities edema. We check it on feet and ankles, in enlarged and sometimes pulsatile liver palpable below the right costal margin, abnormal swelling and ascites, and visible elevation in the jugular venous pressure, sometimes with a large A and V waves that is visible even when the patient is seated or standing. In severe cases, peripheral edema can extend to the thighs or even the sacrum, scrotum, lower abdominal wall, and occasionally even higher, like anasarca. It is diffuse body edema. Edema may be asymmetric if patients lie predominantly on one side. With hepatic congestion, liver may be palpably enlarged or tender. The hepatojugular or abdominal jugular reflux may be detected. Precordial palpation may detect the left parasternal lift or of right ventricle enlargement, and auscultation may detect the murmur of tricuspid regurgitation of the right ventricle S3 along the left sternal border. Both findings are augmented upon inspiration. It is a photo of patient with peripheral edema and especially foot edema, and here you see the test how to check. Yes, it is pressing with the finger and checking is it present some point in this place. It is a looks of anasarca. I told you it is a whole body edema with edema of lower extremities, upper extremities, abdomen, chest, face. It will be present of hydrothorax, of ascites, of even cardiac tamponade. Diagnosis. Sometimes it is only clinical evaluation helps us to put diagnosis heart failure. Just correct objective examination in most cases is enough to put in diagnosis heart failure. It can be visualization. Usually we use chest X-ray, electrocardiography, echocardiography, cardiac radionuclide scan, magnetic resonance imaging. Sometimes we use blood natriuretic peptide or brain natriuretic peptide or N-terminal pro-BNP levels. Other blood tests are not used for diagnosis, but they are useful to identifying cause of heart failure. Other tests for etiology is needed. Clinical findings suggest heart failure, but usually not apparent early. Similar symptoms may result from chronic obstructive pulmonary disease like COPD or recurrent pneumonia, or many by erroneously attributed to obesity or old age. Suspicion for heart failure should be high in patients with history of myocardial infarction, hypertension, or valvular disorders, or murmurs, and should be moderate in any patient who is elderly or has diabetes. And here you see morphological typical pictures. It is a photo with complications of acute myocardial infarction that can lead to heart failure too. For example, in first picture it is anterior wall rupture, on picture B intraventricular septum rupture, on picture C papillary muscle rupture, D fibrinous pericarditis, E mural thrombus, and F ventricular aneurysm. Chest X-ray findings include an enlarged cardiac silhouette, pleural effusion, fluid in the major fissure, and horizontal lines in periphery of lower posterior lung fields, like curly B lines. The X-ray may also suggest alternative diagnosis like chronic obstructive pulmonary disease (COPD), pneumonia, interstitial pulmonary fibrosis, and lung cancer. Electrocardiography or ECG findings are not diagnostic, but an abnormal ECG, especially showing previous myocardial infarction, left ventricle hypertrophy, left bundle branch block, or tachyarrhythmia like rapid atrial fibrillation, increases suspicion for heart failure and may help identify the cause. An entirely normal ECG is uncommon in chronic heart failure. Echocardiography can help evaluate chamber dimensions, valve functions, ejection fraction, wall motion abnormalities, left ventricle hypertrophy, and pericardial effusion. Measuring left ventricle ejection fraction can distinguish between predominant diastolic dysfunction, when ejection fraction is more than 50%, and systolic dysfunction, when ejection fraction is less than 40%. Intracardiac thrombi, tumors, and calcifications within the heart valves, mitral annulus, and aortic wall abnormalities can be detected. Localized or segmental wall motion abnormalities strongly suggest underlying coronary artery disease, but can also be present with patchy myocarditis. Doppler echocardiography accurately detects valvular disorders and shunts, can help identify and quantify a left ventricle diastolic dysfunction. Here you see a picture of echocardiography in patients with congestive heart failure and dilated ventricles and systolic type of heart failure. And it is Doppler echocardiography, which shows us a blood flow, and you see that through the aortic valve it goes aortic regurgitation. That is additional pathological factor for heart failure. Here you see dilated left ventricle on echocardiography, and in this ventricle we see the thrombus into the chamber that fixed on the wall of left ventricle. And it is B mode of echocardiography, which show us regurgitation through the valve tube. Another ways, it is B and M types of echocardiography that shows valve insufficiency or valve regurgitation. And typical view of B mode of echocardiography in different cases: in mitral inflow with Valsalva, and according to tissue Doppler, and left atrial pressure. And we can differentiate: is it present diastolic dysfunction with impaired relaxation, pseudo-normal, reversible restricted, and fixed restricted. And it is checking of different valves of the same patients. You see a B and M regimen in each picture, and in each picture it is specific valve. Cardiac radionuclide scan. It uses very rare for heart failure, but it's possible. It can help assess systolic and diastolic function, previous MI, and inducible ischemia of myocardial hibernation. Like, for example, in this picture, it is myocardial perfusion SPECT, or single photon emission computer tomography study, also called a cardiac stress rest test, is used to evaluate heart blood supply. Two sets of images showing blood flow are obtained, the first following period of rest and second following a period of stress, which involves exercise on treadmill. Cardiac magnetic resonance imaging, or MRI, provides accurate imaging of cardiac structures and is becoming more widely available. It is not a first-line diagnostic tool too. It uses in some difficult cases, but cardiac MRI more and more often uses in today's cardiological clinic. And here you see T2 weight and dark blood imaging of left ventricle long axis, showing a high signal intensity of the left ventricle anterior and inferior wall, sign of myocardial edema. And natriuretic peptide and brain-natriuretic peptide, and N-terminal proBNP levels. Serum NP and BNP levels are high in heart failure. This finding may help when clinical findings are unclear or other diagnoses, like for example chronic obstructive pulmonary disease, need to be excluded when we are difficult in differentiating lung problem and heart problem. Usually they look the same, they can connect with each other, both of them can be, and according to levels on NP and BNP and proBNP, we detect is it primarily heart failure or is it primarily, if they are normal, is it primarily lung failure. Most often it is COPD. It may be particularly useful for patients with a history of both pulmonary and cardiac disorders. I told it. Anti-proBNP is inactive moiety created when proBNP is cleaved, can be used similarly to NP and BNP. And we have F criteria, which named Framingham criteria to diagnostics of heart failure. Diagnosis requires a simultaneous presence of at least two of the major criteria and one major criterion in conjunction with two of the minor criteria. Major criteria include an enlarged heart, S3 gallop rhythm, acute pulmonary edema, episodes of waking up from a sleep gasping for air, crackles on lung auscultation, central venous pressure of more than 16 centimeters hydroargue, water, and right atrium, jugular vein distension, positive abdominal jugular test, weight loss of more than 4.5 kilograms in 5 days in response to treatment. The minor criteria include an abnormally fast heart rate of more than 120 beats per minute, nocturnal cough, difficulty breathing with physical activity, pleural effusion, a decrease in a vital capacity by 1/3 from the maximum recorded, liver enlargement, and bilateral ankle swelling. Complications include encephalopathy, kidney damage or failure, heart valve problems, heart rate problems, and liver damage. All of them can be as a cause of heart failure, as a result, like complications of heart failure. And what I promise you, for the finish of our lecture, I have USMLE test for yourself working at home. An 84-year-old man with a history of severe emphysema and prior myocardial infarction because short of breath with exertion. Physical examination reveals 3/4 hollow systolic murmur at the cardiac apex, S3 hard sound, and rails in a lower lung fields. No lower extremity edema is present. Which of the following is the likely diagnosis? Option A, it is left-sided congestive heart failure. Option B, right-sided congestive heart failure. C, left and right-sided congestive heart failure. And D, it is cor pulmonale. Please think about it and work with this question at home. It is a correct answer on this question with explanation. For today, that's all which I want to discuss with you today. See you on the next lecture. I remind you that it is a finish of cardiovascular system, and from the next lecture we start signs and symptoms of respiratory system diseases. See you in 2 weeks. As usual, if you have questions, please write it in the comments or under the Facebook video. And in the comments, I ask every student who listen in my lecture name, write your name and group number in the comments. For today, that's all. Goodbye.